Okay. All right. Hey, everybody. It's Patricia Potter with Kirkland Solutions. I want to welcome you to the Society of Thoracic Surgeons, Intermacs, and Pedimacs Quality Reporting webinar. Today is October 19th, and we'll go ahead and get started here. I appreciate everybody joining today. I just want to welcome everyone and introduce the STS team that is joining the call today. Today on the call, we have Carol Crone. She is the director of the STS National Database. We have Emily Conrad. She is the patient safety manager, and she has an integral part of the audits as well as the planning and the coordination for AQO, among many other things. And then we also have Leanne Jones, who is the STS National Database Manager for the GTSD and Congenital Heart Surgery databases. So thank you all for joining. And then I would like to also introduce my colleagues at Kirkland Solutions. Today on the call, we have Dr. Ryan Cantor. He's our lead statistician, chief scientific officer. We also have Micio Cleget. Micio is the analyst for all the reports. He gets them all packaged up and sent out to you. He's also responsible for the verification of the data on the reports. We also have John Pennington. He is the director of data management. He's our go-to person for all things data, data sets, and data integrity. I always share this slide, and I just want to go over it again. Today, our COVID-19 update. We encourage televisits if the patients aren't able to come in to clinic to be seen. The quality of life surveys, they can be done over the phone or by mail. It's important to get that data, so we offer other avenues like via phone or via mail to try and get that data. Also, if follow-up visits are done outside of the visit window, please enter the last date of the follow-up date visit into the database. So for example, if the end of the follow-up window was, say, October 1st and the patient was seen October 4th, you can utilize the data from the October 4th visit, but just please enter into the database October 1st because you'll get error message that it's outside the window. So you can still use the follow-up and we can still get it in. You just enter the last date of the follow-up window. So that's the COVID update. And of course, if you have any questions, feel free to reach out to me. I have my contact information that I can share at the end of the webinar today. So if you have any questions about that, please feel free to email me. Okay, Micio, I'm going to just turn it over to you. Micio is going to talk to us about how patients are deemed prior VAD on your reports.
Thanks, Patricia. Hi, everyone. Today I will go over primary VADs versus prior VADs. I have received a good bit of questions of what makes a patient primary VAD or prior VAD. So prior to version 6.0, there are 3 questions that are listed on the pre-implant form: previous cardiac operation, clinical events and interventions within 48 hours. Of all the 3 questions, if you select LVAD, RVAD, or TAH, that would then in turn put a patient into the prior VAD column. Let's see. Yeah. So Patricia, could you go to the next slide, I believe? Yeah, okay. So post version 6.0, as you can see, the pre-implant form was updated and we took away the interventions within 48 hours. And now they're down to 2 questions: prior cardiovascular intervention and clinical events and interventions. And now you can see of the choices that you can select, you can decide whether or not the device is a LVAD temporary or LVAD durable or RVAD durable or RVAD temporary device. So now it's a lot clearer in which device you're selecting for your patients. But if you are viewing your reports and you do not see your patient where you think he should be, please feel free to reach out to me. I think that's it.
Thanks, Maceo. Thank you.
Mhm.
I appreciate that.
And let
And
me make a few comments here as well. Sorry, this is Ryan. Let's see. So this question change where we have more details on whether or not the history before the first Intermacs VAD was durable or temporary went live with version 6, which I believe was late, like November of 2020. So we've only been collecting this information where we can tell the durability of the prior VAD for a couple of years now. I think we're probably on the cusp where if there's enough interest in this type of edit, we could, utilize that temporary versus durable distinction in how patients come out in these reports. So that's something we'll be thinking about for a report edit, in the upcoming quarters. Thanks.
By the time the next reports we got, Ryan, you're right. That would be 3 years worth of coverage. It started November 24, 20.
does anybody have any questions related to this? Or questions related to these questions on the form? If you do, go ahead and put your questions in the Q&A. Okay, so Melissa Williams said, please do only consider durable devices as prior VADs.
Right, that's exactly our intention. Right now, it's including any history on those two questions of durable or temporary. So I think that would be an improvement. Like you said, consider only durable as prior VADs.
Okay, so I'm just gonna move here. Okay, so for the remainder of the webinar, we're gonna have an open discussion. If anybody has any questions related to your reports or any exhibits on your reports or anything report related, this is the webinar, this is the time to ask those questions. So if you want to put them in the Q&A function, we will go through and answer any and all of your questions.
While people think of those first questions, I had one comment without getting too technical. A few sites have had trouble retrieving their zip file packet of reports from the file delivery system. This usually comes down to the local hospital kind of IT security issues. If you have trouble getting that zip file, and you're the site administrator, let us know. We're happy to jump on a Zoom call and replicate the issue and see if we can offer any guidance on how you can access your data.
Thanks, Ryan. And yes, so please do reach out to us if you need assistance navigating or have any questions. And on one of my slides later, I have all the contact information for that if you do need to reach out to us. It's a quiet bunch today, no questions.
Well, even if you don't put, oh, there we go.
Okay, so we have a question here. What is the purpose of mild hemolysis in our data capture? So I'm not quite sure what the question, you mean how is it utilized as an exhibit in the reports, or how is it utilized? So for hemolysis, we have major hemolysis and minor hemolysis. The main difference between the two being, did the patient have clinical manifestations or symptoms? And that's what differentiates mild from major.
We might have to get back on this one. I'm not sure. We don't have our the Intermacs kind of clinical leadership on this call that would be able to answer like why they defined it that way or its use. In terms of like projects and reporting, all we've ever done is look at the frequency and rates of these adverse events. So we haven't. I don't know about this specific purpose.
Thanks, Ryan. Yeah, we can get back to you on that. Get you an answer. I guess while we wait for more questions to come in. Oh, Melissa. Has there been any discussion of only including bleeding events with a severity of 3 or greater in the reports?
No one specifically asked that, but I love the idea of if there are more useful adverse event reporting, let us know. And if there's a critical mass, we could add that. We could leave, bleeding the way it is. I think right now there's the broad, like overall bleeding, GI bleeding, non-GI bleeding. We could add another line of whatever other severity is, as long as the data is collected in the database. So if that's something you'd like, just send me the details send our team the details of exactly what you'd like to see, and we'll review it with STS to think about future report enhancements. And that goes for any of our reporting or data features, anything that would make it more useful combination for your VAD team. We'd love to make those edits.
Melissa, you're welcome to email me that request at patricia.potter@curso.net. Okay, and our next question is, I was curious for feedback from others. Are sites utilizing bridge to transplant likely, moderate, and unlikely as device strategies? Yes, if any other sites would like to chime in, or John, if we, have ever looked at the frequency and how often those selections have been made, we could discuss that. Next question.
And I don't know, not speaking for other sites, just in terms of how that data gets utilized, we do see that like there's information in those answers. Patient that is unlikely is much closer to a DT patient in terms of characteristics and outcomes than VTT likely. So there is useful information in those distinctions, but I don't know. But that's more like in how we use the data in analysis. I don't know how sites use that data.
We got another question here. Will the same driveline infection count twice if the patient is readmitted? Same bug. Do you want me to answer that, Ryan, or would you like? I'm happy to if you'd like.
I'll say one quick thing, and then if you mentioned the definition. Okay. So the way all of the adverse event reporting works, if there's an event that meets the definition, here we're talking about infection, every form will get counted. If it, says driveline infection, it'll get counted as a driveline infection. So, and then Patricia, maybe you could comment on when you would only enter one form versus two forms.
Yeah, absolutely. So thanks, Ryan. Yeah. So just starting off, every rehospitalization does need to be entered. So even if the patient is having multiple rehospitalizations for chronic driveline infection, they do need to be entered, but those rehospitalization forms don't count towards multiple infection forms. Like Ryan said, we only count the number of forms that are entered. Now, we know, a lot of these patients have chronic driveline infections, and they're hard to get to go away. So we don't ask you to enter a major infection if the patient has a swab done and it's the same organism as prior to. So once an infection is entered, it's entered. Now, the caveat to that is if the patient has a change in treatment, so if they change from PO to IV antibiotics, we consider that an escalation in treatment, and that does warrant a new major infection form. If the patient goes in for a procedure related to it, so if the patient has to go in for multiple INDs, you do need to enter that. So if the patient has multiple INDs within one admission, that's just one. But if this patient is now having ongoing treatment, then each of those infections does need to be entered. And I do have an FAQ on this. It is available on our website because I know this can be really confusing. So feel free to reach out to me if you have any questions, any specific questions about what's going on with your patient. I can help you determine if an infection form needs to be entered or if it's covered under a previous infection that had been entered. So I hope that answers your question, Rachel. Just kind of an overview. It's counted by the number of infection forms that are entered, and sorry, I lost my train of thought. It's counted by the number of infection forms that were entered, and whether or not an infection form needs to be entered depends on if it's the same organism and the same treatment, or the reinitiation of a treatment. So I'm sorry, I know that's kind of a long-winded answer, but it is specific to each scenario. Okay, next question. When completing the comorbidity section, should we only report new comorbidities or any of the comorbidities present at the time of visit? So we would like you to report any any previously existing comorbidities that are part of their past medical history, and of course capture any new comorbidities that now may be present at the time of visit.
Let me make a comment here. I think one of the questions got cleared before we answered it, from Brooke Myers on it'd be nice to have future reports differentiate minor versus major device malfunctions. I think, and you might have to correct me if I'm wrong, Patricia and John, I think that distinction between major and minor came out around the same time as that version 6 in 20. I can't remember exactly.
It did. It was all part of that revision. Right. Yeah.
No, it was a year later.
Okay.
The A's were revised almost 2 years ago today. It was 10/29.
Okay. And then there is that, I mean, that major and minor definition, question selection is like the second or third level kind of child question in the device malfunction form. Is that true?
That's true. Okay. Yes.
Yeah. So if that's clearly defined in the database, that would be a natural extension of that form. We break out some of the subtypes for other forms, so we could do that for that form. Maybe email Patricia as well with that specific request, so we have that, and then we'll put all these requests in front of STS to get timelines and prioritization of report edits. So good idea.
I don't want to confuse it, Ron, but would it also be potentially something for us to throw in our bin for future dashboard edits to add that as a filter?
Potentially.
I'm not saying we should. I'm just saying maybe throw it.
Yeah, definitely. Yes, add it on the list for discussion for sure. If that's a area of interest, then yes.
We have a comment here. I utilize them on every visit. I created a source document that I have the provider fill out. I'm trying to remember.
Was that the analysis question, or there was another question on the purpose of Or no, or the sites, asking the sites about, let me go back to the question. Oh, how are the sites utilizing BTT likely, moderate, unlikely, maybe? I'm not sure.
It might be that one. Utilize them on every visit. I created a source document that I have the provider fill out. I'm not sure which question that was in reference to. Oh,
Oh,
yes, yep, the patient
question.
status question. Yeah, okay. Great. And then for follow-up visits, when asking about prior sternotomy, should we count the LVAD implant? No, don't count the LVAD implant on that prior sternotomy question. Should we be documenting admissions that are less than 24 hours? No, no. Unless the stay is 24 hours or more, you do not need to complete a rehospitalization form. Will you be discussing the upcoming database changes regarding ECMO documentation, or will that be at another meeting? Fatima, yes, we're not, no, we're not going to be discussing the ECMO documentation changes during this call, but we do have a user group webinar call next week on October 25th, and I will go through those changes and show you the new questions on the forms, and we will cover it there, and I'll be available for questions. Is there anything being done with the association data for AEs, patient-related versus management-related? So those were new questions, relatively new questions that have been added to our forms of, was this a patient-related event or was it management-related? Ryan, have we done any kind of analyses or done anything with those questions?
No, in terms of like STS, A&P type projects, I've not analyzed any of that. So that might be a great idea for either a A&P proposal. I don't know what other options there would be, but that sounds really interesting.
And then we just have a comment here that would be nice for minor major hemolysis. I'm not sure. Oh, I wonder, is this in regards to the question of patient-related versus management-related for the hemolysis comment? Let's see. All right, the next question is, usually we use bridge to transplant, not likely if they have been considered for transplant, but not a candidate for XYZ reasons. Sometimes they can be reconsidered if things change, like losing weight, proving consistent sobriety if they relapsed, or having better support, but the odds are probably against them for becoming a candidate. For moderate or likely, it's kind of a toss-up with your judgment if they're being worked up for transplant and meet your site's criteria for selection. Yeah, absolutely. So when doing the follow-up after LVAD implant, we disregard the sternotomy done for the implantation. Yes, that's correct. This only means sternotomies done prior to VAD. Yes, that's true. So any sternotomy, so like if they had a cardiac surgery like a cabbage prior to VAD, you would count that one, but not the VAD. However, if the patient was to receive a device exchange and had a subsequent second sternotomy, you would count one because they did have a prior sternotomy for VAD number 1. To clarify on the follow-up visits, the LVAD sternotomy does not count as a prior sternotomy. Yes, that's correct. It does not count as a prior sternotomy. Any update on having the option for more than one person having access to the dashboard after the conference? So I know this came up during the AQO conference. Right now, we're only offering for one person at each site to have dashboard access. It's typically designated to the site admin or the person who had been frequently in the dashboard, had the most accesses. We granted it to that person that looked like they frequented the dashboard most. But as of right now, there is just the option to have one person to have dashboard access. Okay. Can you explain timing of stroke, recent versus remote? It says recent is within 30 days of admission, but I'm not sure what admission this is referring to as we fill out this question at every follow-up in the comorbidities section. So a recent stroke would be a stroke that occurred since the last follow-up. And we do continue to follow the strokes. So once a patient has a stroke, the answer would be yes, moving forward. I hope that answers your question. Alondra, is it possible to not have to complete the comorbidity section at every visit if there are no changes from the previous visit? It's a really good question. We've talked a little bit about this in the past, about possibly having the data from the previous follow-up visit carry over to, so say you have your data from your 6-month carry over to your 1 year. We've talked about that, but we've decided not to do that just because potentially things could be missed, anything new that came up. So, and it'd be enticing to just hit validate and submit without reviewing it, and potentially something could be missed. So at this time, we're not gonna be making that change. Colleen, in the pre-implant form under medications, it gives options for currently using, known previous use year, etc., but then changes to yes, no for Entresto, nitric oxide, and phosphodiesterase. Do you select yes for being currently on or yes for any time in the past? Colleen, I'd have to look at the form completely, but I believe at the top of the form, on the pre-implant form, on the medications form, it does tell you how far in the past you can look at. So it is yes for any time in the past, but I believe that there are parameters. I'd have to look at the form to tell you how far back a yes would be for. But it is for currently using and in the past, but I'd have to look at the form. Sorry, clarification. Hemolysis is a drill down for analyzed data, minor or major. Yes, we have minor and major hemolysis, like the device malfunction discussed earlier. The minor does not have any clinical manifestations, just labs, and that could possibly be inaccurate. So right now, our definition is for the differentiation between major and minor hemolysis is that for major hemolysis, they do have clinical manifestations, clinical symptoms, and minor does not.
Patricia, jumping back to that timing of the stroke, because I hadn't really looked at that question before. Is it,
Yes.
when it says the within 30 days of admission, would it be fair to say within 30 days of follow-up visit instead of admission there? Is that like what the timing is? Does that make sense?
Yeah, I'd like to look at the form just to, who asked that question?
There might be like, once you review it, there might be like a slight updating or clarification of the language on that question that would make it like really clear at the time of data entry.
Yeah, because I don't think admission is the right word for that.
Yeah, I think follow-up visit would be, but yeah, take a look at it at your.
Let me just make a note of that and look at it.
Thanks.
Thanks, Ryan. I appreciate that. Okay, Sarah, once a patient has a stroke and it's stacked moving forward, it always asks for the modified Rankin score. This is not typically done. Do we have to use physician documentation, or you can estimate based on clinical documentation if the patient is still having symptoms? Is there a better way to calculate loop diuretic dosing day at the 1 week and 1 month follow-up intervals? If a patient is on and off a drip, this makes the calculations cumbersome, especially looking back over 2 to 3 weeks. Yes. So typically, yeah, we do ask you to just take an average calculation of what the patient has been on. I do see that that is cumbersome, but it's kind of the way the question is designed right now. Any other questions?
Probably give people just a few more seconds here. Thanks for all those great questions. And like I mentioned, any feedback that you guys have on the reporting, the reports themselves, or any of the data features, the dashboard or the outcome analytics or form download or anything that you guys use at your site, let us know any ways that we can help with that. And if you have something that's particularly useful, consider presenting it at AQO next year.
Yes, we would love to hear how you utilize your report data at your site, and I'm sure other sites would really love to, hear that as well. And AQO is a great place to showcase that. Sue Ellen, yes, I believe. Okay, so Sue Ellen was asking, could we add Remdesivir and Paxlovid to COVID-19 treatments? Yes, I think I have a ticket in to have those added, but thank you for the reminder, and I will double check on that. Let me just make a note here. And the next question, back to the association data. Is this something you can see being in the quarterly reports in the future with AE data? I could see the physicians being interested in this data.
I need to look and see the distribution of those answers. I mean, we certainly could calculate, for certain key AEs, like the underlying rate for the two different statuses of those things. It might be like a lot to do all of the adverse events, but if it was targeted to a few key adverse events to start with, it'd be easier to implement. But if there's significant interest, we could, consider ways for it to be, across several adverse events. But I could see incorporating that into the The QA reports, yes. And then the one thing will be, you know, we can only analyze that once the question went live. So it'd be like a sub exhibit, something like that. Thanks.
Okay, I think it would be great if the first durable VAD, even if patient has a balloon pump, Impella, were counted in the primary implant.
Yes, that makes a lot of sense. That's what this edit would accomplish.
Will there ever be an option to say the patient declined doing the trail making just for track purposes of why it's not completed? Alondra, I'd have to look and see what, I can't remember off the top of my head what the options are to say that it was not done.
I have the form pulled up right now. It's the completed, attempted but not completed, not attempted, completed but invalid. So there's not specifically a option for patient refuse or patient decline.
I can
Like
see
that,
even adding that for all the exercise function stuff, like the 6-minute
Yeah.
walk. I mean,
Mm.
and adding those things to drop downs are pretty minor ask.
Okay, that sounds good to me. We could talk about adding that. Thank you, Alondra.
Yeah, because that's a little bit different than not attempted to
Right,
say.
or it's not completed. It's like, well, why
Yeah.
wasn't it completed? Yeah.
Yeah, and actually I'm looking and at like 6-minute walk has patient refused. So we already have similar responses for other questions in that section.
Okay, good suggestion. Thank you. We'll look at adding that in. What else? Feel free to put your questions in if you have them. While we're waiting on more questions, I just wanted to share the report distribution calendar and the coverage stop dates for each of the quarters here. And what else? We do have lots of resources for you all. I included the web address where you can find resources for all things Intermacs, Pedimacs, the user guides, the data collection forms, quality of life surveys. We do have a training video for version 6.0 on that site. And I also have an FAQ document on that site for Intermacs. And then we do have 2 email addresses. One, if you're having difficulty logging in, trouble with your password, you can email intermacs@curso-admin.net. Or if you have reporting questions, you can reach out to our reports email address, reports@curso-admin.net. So lots of resources are available. And then here is mine and Catherine's contact information. Our email address is kholyfield@sts.org, and I am Patricia at patricia.potter@curso.net. Feel free to reach out to me if you have any questions or if you need any data corrections. I can also assist with that. And like we had talked about, you know, if you have a patient that has a chronic driveline infection or anything that you're questioning, you know, does this meet the Intermacs or Pedimacs definition, feel free to reach out to me and we can kind of chat via email, or if you want to jump on a Zoom, I'm always available to do that as well. And we can kind of talk out the patient scenarios. And then any database operational questions can go to intermacsfaq@sts.org. We do have a Intermacs user group webinar next week That will be on October 25th at 1 p.m. Central Time. And I will go over the upcoming changes for capturing the number of days the patient was on ECMO. So we will no longer have to explant a device if it is attached to an oxygenator. So make things a little bit more streamlined and more accurate. So I will go through that next week, and I'll also be available for Q&A as well. What else? Does anybody else have any questions? Feel free to put them in the chat. Ryan is on here. If you have any reports questions, now's a great time to ask him if you do have any questions. And just to circle back, I will look at the wording for the recent stroke, and I'll get that clarified for you all. And we will add the COVID-19, Remdesivir and Paxlovid. We'll add those to COVID-19 treatments. And we will look at adding patient reviews to some of the quality of life answer options. Anything else anybody had a question on, or anything anybody need me to get back to them on? I've got some notes here.
A really great webinar and lots of engagement. So thanks, Patricia. Thanks, Ryan, and everybody.
Thanks, Carol.
Sean and Maceo.
Thank y'all.
Yeah.
If you do think of something after the webinar, feel free to send me an email. And you can ask me your question then. And if I can't answer it, I'll get you to the right person that can. Thank you all for joining, and I will talk to most of you next week at our user.
Woohoo!
Great call, Patricia.
Yeah, great job, Patricia.
Thank you all for your support. Appreciate it.